Welcome to the webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled Actionable Insights, Key Steps to Engaging Patients in Psychosocial Interventions. Before we get started, please note this webinar is for informational purposes only. Please consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collective product of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care. This webinar will cover the ins and outs of integrating brief psychosocial treatments into primary care practices. Experts will discuss the spectrum of brief psychosocial interventions such as psychoeducation, shared decision-making, and motivational interviewing, along with how best to use them to help address behavioral health needs for both adult and pediatric patient populations. Joining us today are Dr. Cody Hostetler, Clinical Director for Behavioral Health Integration at Nationwide Children's Hospital, and Assistant Professor in Pediatrics at Ohio State University, and Dr. Patrick Rowie, Professor of Psychiatry and Behavioral Sciences at the University of Washington, and Associate Director for Evidence-Based Psychosocial Interventions at the Ames Center. And with that, I'll turn the conversation over to you all.
Thank you. I do have one disclosure to disclose. I will reference a book that I co-authored and also included it in the resources section at the end, and I do receive royalties from that book from the American Academy of Pediatrics.
And these are our learning objectives for today. First, to describe the value of brief physician-delivered psychosocial strategies for both adult and pediatric patients, to name 3 evidence-based psychosocial strategies, and to describe the components of shared decision-making strategies.
So I don't think we have to spend a ton of time making the case for folks who are attending this webinar, but I do think it's worth highlighting a few reasons why this work is so important. And the first is that we know behavioral health concerns are common and that they were common even before the pandemic, but even more so since the pandemic started. We also know that compared to behavioral health clinicians, primary care clinicians are seeing a very large range of mental health and behavioral health needs in their clinic, ranging from very young children all the way through adults, and from subclinical symptoms to very severe symptoms that are presenting in the office. We also know that due to several factors, patients have really a lot of difficulty accessing mental health specialists or behavioral health specialists. And that limited access often results in undertreatment, and then those behavioral health problems lead to negative outcomes. We also know that training medical clinicians in engagement and communication skills can really help improve those outcomes for patients. And we're really going to spend some time talking about what those engagement and communication strategies can be to help our patients take a nice first step into getting the care that they need. So when we think about delivering behavioral health care within primary care, we really think about 4 different levels. The first one is just identifying that there's a need. The second one is moving towards engaging patients in psychosocial interventions, and that's what we're going to be spending most of our time on today. Things like providing psychoeducation, engaging in motivational interviewing, and working through shared decision-making to come up with a treatment plan with patients. And of course, there are additional levels, including providing brief psychological interventions within primary care, as well as referring patients outside the practice to that longer-term psychotherapy when it's needed.
And I'll just add there that we certainly understand the time limitations that physicians have in their visits, and typically that second level is often turfed appropriately to a care manager. But I think part of the goals that Cody and I have for today are to talk about some really brief strategies that physicians can use in the context of their visits as well. And in that vein, we certainly acknowledge that the primary care physician is really the most important ingredient for success when we think about engaging patients with both healthcare as well as behavioral health plans. And it's the PCP really has the primary treatment relationship and is responsible for developing mutually agreed upon treatment plans with patients and linking them to appropriate integrated team members. And that existing relationship, we also want to acknowledge that the recommendations that come from PCPs are really very powerful. So their relationship with patients is really the foundation for patient engaging in many different kinds of care, including behavioral health care. The PCP sees the whole picture and is aware of the roles of every team member. And key messages here are the importance of communicating to patients that there are a variety of treatment options for their behavioral health concerns. And this idea of what we call proactive persistence, that we communicate upfront that sometimes or often the first treatment approach for a behavioral health concern might not be as effective as the patient would like it. But there are a lot of options, and that we'll work together to monitor how you're doing with the treatment and how you're responding and adjust that treatment or intensify it as necessary. And overall, a message of hope that we're doing this together and we'll work together until we find good solutions.
One of the first things that we do to kick off that conversation is what we call psychoeducation, which really means providing information about the symptoms and the impairment that they're experiencing, oftentimes summarizing that information that they already shared with us. And then the second part of that is really sharing that medical term that we use to describe those symptoms and impairment, and knowing that that could look or sound very different depending on the patients that you're treating. And I think it's helpful to have a shared understanding that in my training, we call it this, and to maybe even ask about what does this collection of feelings and actions look like to you, and what do you guys call it in your family or in your culture? It's also helpful to share what we know about the causes and the prognosis of what you're struggling with, and to kind of prepare them for understanding it, what causes it, and where it's going to go, especially if it's left untreated. And then it's also important to let them know about what treatments are known to be effective, as well as those treatments that we've studied and are known to be ineffective, and maybe even those treatments that we don't know much about yet. And then helping patients develop a self-management skills and really empowering the patient to take the next steps to help them understand what it is they're struggling with, where it came from, where it's likely to go, and what the next steps might be. And also providing some space for them to be able to ask questions, address their concerns, address myths, and even maybe talk about some of those cultural differences that might exist in our understandings of it, and leaving room and space for that, as a provider, this is the way that I think about and talk about these things, that I'm curious what these symptoms and what these impairments really mean to you and to your family.
Cody, I like what you said at the beginning about providing information and talking about medical terms, and then checking in with patients about whether that's, how the terms that they use to describe it. So psychoeducation is more than just providing information, right? It's engaging in a give and take conversation with patients and family members as appropriate. What do you know already? What if this is true for you personally?
Absolutely. That checking of understanding and getting an understanding of their understanding.
So we're moving on to our second powerful strategy, which are, style of communication that we call motivational interviewing. Now, this was originally developed as a formal longer-term intervention for alcohol use disorders, But we think of motivational interviewing as sort of an umbrella set of strategies that can be incorporated into all of our conversations with patients. Firstly, motivational interviewing, or MI, is a collaborative, goal-oriented style of communication where we actively seek out to get patients' experience and their perspective, in contrast to a more traditional, maybe paternalistic approach where the physician always knows best for the patient. MI also pays attention to the patient's language of change to check in with their readiness for changing this particular distressing symptom or condition. MI strengthens a patient's personal motivation for change and their commitment to a specific goal. It elicits and explores a patient's own reasons for change. And overall, our goal with these strategies are to create an atmosphere of accepting where our patients are at, what they're struggling with, what their goals are, and communicating compassion about their situation. So regardless of whether patients are ready right now to make a particular change, we're creating an environment where they feel understood and accepted, and we've established a relationship where they can reach out to us when they are ready to make a change. So OARS is a model of good communication skills that has been adapted from patient-centered approaches and using motivational interviewing principles. And it really provides us with a format to help us be intentional when we work with our patients. So this is an example of an adult patient who is interested in becoming more physically active, but has a lot of ambivalence about their ability or their motivation to do it. So we start with O for open-ended questions. And an example could be, what has worked for you in the past in being more physically active? And so you'll notice when we use this kind of question, we're encouraging the patients to do most of the talking. And this gives us a lot more information and understanding about our patients and facilitates them in making the most kind of informed decisions that they can make. We may be tempted to give a suggestion or advice like, have you thought about teaming up with a friend to be more physically active? And of course, that's coming from a good place, but it can be a lot more powerful to hold off on the advice and ask some open-ended questions. A stands for affirmations. An example is, you've done a good job in the past with this. It sounds like you're ready to tackle this again. So we're really reinforcing the strengths that the patient has and communicating that they know best about how to take care of themselves. R stands for reflective listening. An example would be, I hear you saying that you've been feeling lower and less energetic than usual, but at the same time, you'd like to increase your physical activity. So this kind of comment is really showing that we're listening to the patients and we're observing body language if that's appropriate, and kind of reflecting back to them their feelings and really shining a spotlight, particularly on what we call change talk, things that they would like to do to make positive changes in their lives. And lastly, the S stands for summarizing. An example would be, so it sounds like you'd like to try out walking more during your lunch break, and maybe starting slowly with 1 or 2 times in the next week. So this is kind of ties a bow on this conversation, and also in the spirit of good time management. You've transitioned and you've kind of gotten closure and you can move on.
And when we think about teens, a lot of this stuff works as well for them. So when we're thinking about a kid who might be feeling anxious and depressed and having some low motivation, which is affecting their ability to be successful in school, we can use that same formula. Things like open-ended questions. We really like to do this particularly for kids who screen positive on the PHQ-9, because we know that depression can present so differently from kid to kid. Sometimes it's sadness, sometimes it's irritability, and just starting with an open-ended question of, how would you describe what you're going through or what you're feeling? What words would you use? Because then you can get an understanding of the way that they describe their situation, and then be able to reflect those back when you use your R skills. So affirmations could be, I remember when you were struggling with math and got a lot of extra help to improve your grades, right? So we're really focusing on something that they did that showed that they cared about this or that they are capable of doing this. This is particularly challenging, I think, sometimes for us as adults, because what we often want to do is we want to praise kids all the time, right? I'm proud of you for doing, but then it becomes about us and our motivations and not about the kids and the kids' capacity. So one of the ways that we often think about this is almost like an equation. You plus this behavior means something, right? It means that you're motivated, means that you're capable. And oftentimes phrases that start with I are praise. And while those are important and strategically placed when you're trying to get somebody to change their position or to uptake something new, oftentimes those you statements can be even more powerful. So you did this, and that means that this is important to you or that you're capable of doing this. And those reflective listening skills, saying things like, I hear you saying that it's been hard and that you've been feeling more depressed and anxious now, but you're also unsure about how to talk to your parents about getting help for this, right? So we're just kind of reflecting and summarizing some of what, or reflecting what they're saying, and then moving that summary at the end to do one of two things: to either highlight the pieces of information that you found to be important, or that change talk that you heard to really emphasize that, or to pivot and to change the conversation into the next steps and for the sake of time management. So it sounds like we have a plan that you're comfortable with. Sounds like you're okay looking over these handouts that talk about what depression is and how it's treated. And the next time we can talk a little bit more about some options for you getting help. And for now, it sounds like you're interested in just saying hi to our integrated behavioral health provider and get to know them today, but maybe not get started in any kind of treatment, and just really being able to focus on the plan and the things that they're willing to do and the motivations that they have for change. So pivoting a little bit from motivational interviewing to think about why shared decision making can be so important. The motivational interviewing and psychoeducation are two really important components to helping understand and build motivation and engagement in patients. Shared decision making is really the time to start exploring and making a plan. And we know that this is important because only about 10% of adult primary care patients who have some behavioral health concerns receive care. And that number isn't much better for pediatric populations. We're talking about 18%. And that, it can even be a struggle to get those patients to link, even in integrated care models where we know access improves. But oftentimes that linchpin, that transition from seeing their medical provider to the BHC is often a place where things get hung up. And the way that we communicate and build those plans and those handoffs can be really important to ensure the success. That handoff, that not involving them in that decision can often lead to poor adherence to the strategies that we're providing or recommending, or the referrals that we're giving, or the recommendations that we're providing. And it can also result in low referral completion, attendance, or engagement with behavioral health clinicians, particularly even those that are in your clinic. So you might be recommending that they follow up with a care manager or an integrated behavioral health provider. But if we're not giving them the option, they may be making that appointment and not attending it, which results in a lot of kind of not efficient practice and a lot of unfilled slots moving forward within the behavioral health provider's schedule, and then confusion about the patient and the behavioral health provider and the medical provider about why that link didn't happen. So shared decision making can really be an important tool to really seal that transition from the medical provider to the behavioral health provider. It can be a really important strategy to achieve really good patient-centered care. And Patrick, I don't know about you, but the way that I like to think about this is it's when you really combine good psychoeducation, motivational interviewing, and shared decision making, it transitions our job from telling patients what to do to really helping them and us understand why things need to change and what the change needs to be. So it's not telling them what to do, but helping them understand what they need to do.
Good. So before we, present some of the, components of good shared decision making, we did want to review some of the research about this. And the research originated not in mental health, but in care for medical conditions like cancer. And so pretty robustly across, all sort of different conditions, we know that the great majority of patients want to know and get information about what they're going through and what are the treatment options. Interestingly, patients express different levels of interest in actively participating in treatment decisions based on a few factors. So we know that older adults, those with lower education, and those with more severe medical illness want their physicians to be more active in treatment decision-making. Now, this doesn't mean that we abandon shared decision-making in these patients, but it's really helpful to kind of know some of those trends when we work with our patients. And again, across the board, very robust findings that kind of ask patients retrospectively after a medical encounter, and patients across the board report that when they felt that their clinician was warm and empathic, asked them a lot of questions, encouraged them to ask the clinician questions, and patients who felt that they had some involvement in the treatment recommendations showed improved health outcomes. And that's really robust, and we give some references there, both classic and newer ones. Another line of research is beyond the retrospective reports, are looking at the impact of what we call targeted shared decision-making interventions for, again, a number of medical conditions. Now, these could be focused on, talking with clinicians about how to improve communication with their patients and how to involve them in decision-making. It can also be testing out formal decision aids. And these are simply, reflecting good clinical care, but in a more systematic, structured approach. And these aids can range in sophistication from, very simple, straightforward pamphlets to more interactive web-based programs. And the VA has a number of good online decision aids. Lots of research has shown that these interventions across medical conditions lead to a number of immediate positive impacts that patients report that after these interventions, they felt that they have more knowledge about treatment options that are available to them. They have more realistic expectations about different treatments, and they're more likely to receive what it is they want and initiate it and adhere to that treatment. A few special considerations that we do want to highlight that the research has shown that racial and ethnic minority patients report that they feel that they've received less information from their clinician about their medical condition. They also report less respect than white patients for what their treatment preferences are. And if we look at the literature for older adults report fewer experiences of shared decision-making in their care. As noted before, a greater acceptance of the physician's traditional role, and not surprisingly, greater medical burden and other physical limitations that can impact their interest and participation in shared decision-making.
Then when we think about for kids and adolescents, I think one of the things that can be challenging or something to consider doing shared decision-making is that balance between children and caregivers, right? So that you might have a child who maybe doesn't want to be on ADHD medication and the parents do, or you might have a child who wants to participate in therapy, but the family would prefer to keep the things that the family's struggling with within the context of the family. And so I think when you're working with kids and adolescents, making sure that you're hearing both the parents and the children's perspectives and kind of weighing those can be really important. And then this becomes even more important when you consider cultural differences and the dynamics of decision making within families, especially as acculturation differences start to occur.
And Cody, that makes me think of something I didn't say about older adults, is that in many cases, they may have a spouse or a family member attend their visits too. So it's really important to be aware of their preferences and values as well.
Absolutely.
So here, moving on to shared decision-making for behavioral health conditions, we wanted to give you an idea of, what are some of the key intervention components. And we really encourage, I think a lot of people translate shared decision-making to just honoring, what the patient asks for in their request. And of course, that's important, but true shared decision-making is a little bit more of a clinically sophisticated process that we outline here. It takes a little bit more time. And we say that it starts with reviewing and really understanding a patient's behavioral health symptoms, what they're experiencing, and the impact on their functioning. What is most distressing to patients and what have they noticed? That segues into providing depression psychoeducation. As Cody was talking about earlier, this is providing information, but it's also a conversation and asking patients what they know and what they feel about these things. We also move on to eliciting from patients what if they've had prior treatment experiences, helping them with these behavioral health concerns, what their preferences are for treatment walking in the door before kind of engaging with us about different options of pros and cons, and what their values are. So an example could be somebody values being a dependable worker, and they're really concerned with the impact of depression on their work performance, and they've noticed that they're not as productive as before. It's really difficult for them to concentrate. It's really helpful to know that's a primary value for a patient, or that somebody really values being a good parent, but they find that since they becoming depressed, that they're more withdrawn from their family and they're getting more irritable with their children. This is an example. The next intervention component would be to use some kind of decision aid material, whatever you have at hand. Again, it doesn't have to be anything fancy. It could be a simple one-page form describing different treatment options and what they look like. And we're going to show you some examples later in our presentation. Ultimately, we want to, after this process, which can be, relatively brief, arrive at a mutually agreed upon decision about a treatment that the patient is willing to kind of try out and offer that treatment.
I love those. I think it really walks you through each step of the shared decision-making process. And, on the next stage, we often, when we first take our first step into it in clinic, I'm lucky to work in a resident continuity clinic. And when we're training the residents on shared decision-making, we like to kind of have a careful heuristic for them, a way of kind of breaking all these steps down into something that they can remember and maybe even having posted in the clinic. And so on the next slide, we kind of break it down into these simple 3 things. So once you've kind of done your psychoeducation as part of your motivational interviewing, we like to talk about team talk, option talk, decision talk. And this is really a kind of a streamlined 3-talk model by Elvin and colleagues that can be a really nice place to start off the shared decision-making journey, particularly as you're trying to develop this skill. And the first one is just transitioning into team talk, right? So for context with motivational interviewing, we like to give permission or get permission before moving to the next step. So saying something like, I hear that this has been a big problem for you. Is it okay if we go ahead and start working as a team to come up with a decision that best suits you, right? So we're already starting that conversation off differently. These are my prescriptions or recommendations to you, but let's work as a team in order to come up with a solution that best suits you, right? So step 1 is team talk. Step 2 is option talk. And this is where we explore the different alternatives and the different options that exist, perhaps using a decision aid as we had talked about. So we're going to do this as a team. Let's talk about the options and let's start to think about the pros and cons of some of those options and then move into decision talk. So tell me what matters most for you for this decision. When you think about all these different options, what are those values, as Patrick was mentioning? What are those things that you really want to see get better? And what are those parts of your culture that really is important to know as we go and move into this, making this important decision for you in your care? And so what we find is that when we're first starting to take this step, remembering all the steps can be difficult, but this kind of three talk mnemonic can be really helpful to get started. Team talk, option talk, and then let's make a decision together that best suits you.
Great. And one of our intervention components was providing psychoed, and this is an example again, as Cody said, of how shared decision making incorporates, our psychoeducational strategies. These are forms that I'm happy to distribute if folks are interested. But it's an example of something that can guide our conversation about what depression is, what are the key symptoms, what we know causes depression, and how to, a brief intro about how depression is treated. And this can be initially discussed in session, and then, we can give this material to patients to take home and think about too, and get them to think about questions that they might not have asked in the first session. The second form is one of the common behavioral treatments is something we call behavioral activation that helps support patients kind of re-engaging in activities that are rewarding and pleasurable to them, but they've stopped doing since becoming depressed. It's an example of a form that might be helpful that you and or your care manager might use to support ongoing work with the patient about describing, regardless of what caused their depression, this is this vicious kind of cycle that's happening, and increasing pleasurable, rewarding activities is one way to unwind that vicious cycle, sort of a self-management approach.
I love those. Those tools can really help you be more efficient in your practice. And also, some of the things that we're talking about sound complicated and heady, and like they might take a lot of time, but there are ways to develop scripts. And I would really recommend that you come up with some transition statements and scripts that help you be able to provide this care in an efficient way. For example, when we're providing psychoeducation about depression for youth, we're talking about a lot. You have to validate, you have to listen, you have to normalize, you have to provide hope. And that could seem like a huge task, but you can come up with these kind of brief transition statements that can help you move through that process pretty quickly. Something like, I can see how hard this has been for you, right? That's validating. I'm seeing you, I'm hearing you on what you're saying. And then you can say something like, I've seen a lot of kids your age going through similar things recently, and we've really been able to put together a plan that helps by working together, right? So we're validating, we're normalizing. I've seen other kids your age go through this, and we're providing hope that I've actually been able to work as a team to provide some recommendations and to build a plan that actually works really well for them. And then follow that up with getting permission to move forward as a team to start putting together that plan. Would it be okay if we put together a plan for you today? So we're hitting multiple components over the course of just a few sentences to really drive some of those things home and to pivot and transition to the next part of our visit. One of the other things that when you're working with kids and families that I think is important that comes up a lot when you're working around psychoeducation is really differentiating depressive disorders from adjustment disorders. We hear in clinic all the time from parents about not understanding how their kid could feel depressed given their context. And I think when you're working with adults, a lot of the time, they know they're depressed and they know their situation, or they know at least how they're feeling and the context in which they live in. But I think when we're providing this education to families, I think families sometimes step in and accidentally invalidate that for children. And so one of the things that we like to talk about is to say, I hear that you've worked really hard to give your kid a better life than what you had. And it could be hard to understand after doing all this work and knowing what you've been through as a person, to see that your child's feeling depressed, even though you've worked so hard to create a better context for them. But really, depression is feeling sadder or more irritable than we would expect given their situation. If they were feeling sad about a specific thing that happened, we actually wouldn't call that depression. We would call that an adjustment disorder, that they would be adjusting to this difficult thing that happened. And so I think for parents, oftentimes when you're providing psychoeducation or there's a difference between kind of their expectations or their understanding, I think being able to provide some context about what these diagnoses mean can be really powerful and prevent some of that invalidation from happening. And then the last piece that we like to share when we talk about psychoeducation for kids is some of this content can be pretty heady for them, right? Pretty academic or pretty abstract. And some kids have a hard time thinking about depression and thoughts and those kinds of things. So we really like to talk about depression or anxiety as a bully or developing a character. You know, there's movies that show feelings as emotions that live inside the brain, or little characters that live inside the brain. And I think that can be a really useful tool when you're working with kids to provide psychoeducation at a level that they can comprehend. And again, that doesn't have to take a long time. And it can really help set up the evidence-based treatments that exist. Something like, you know, depression can kind of be like a bully that stops you from doing the things that you want to do and the things that you need to do, right? That's kind of the behavioral side of it. It might say mean things to you. That's the negative thoughts that might happen, like you're a failure or you're worthless or nobody's going to like you. And that it sometimes tricks you into only seeing the negative things that happens, all because it wants to stay in control and keep you feeling down. Sometimes we even like to name the depression bully that kids are going through, so kids can actually have a term for it, and they can name it, and they can talk about the thoughts that it gives them. And that can be really helpful, right? Because to have a thought that I'm a failure sounds like a statement of fact. But if I say my depression bully is telling me that I'm a failure, now it sounds like somebody's opinion. And so by being able to kind of change our psychoeducation to make it a little bit more kid friendly, oftentimes our kids and adolescents can buy into those things and the treatments, and set up why we're asking them to go to school and to do their chores and to hang out with friends even when they don't feel like it. It can help them feel like they understand why we're doing that. It's not because we don't understand them. It's because they have a bully in their life that we need to push back against.
Great. So when we're discussing treatment options with our patients in the context of shared decision making, it's really important to keep in mind that ultimately that the treatment that the patient tries that works is the best treatment for them, and really paying attention to patient-centered care means attending, not necessarily to what we want the patient to try, but what their preference is. It doesn't mean that we ignore the evidence base, right? If a patient is really wanting to try an herbal remedy and we know that the evidence doesn't support that, we certainly speak up about that. But we really want to pay attention to what the patients want to try and support that. And one size doesn't fit all. That medication isn't right for everyone and won't work for everybody. Conversely, psychotherapy or some brief behavioral approaches are not right for everyone too. It's also important to keep in mind that one size does not fit all for psychotherapy too, that there are a lot of different kinds of psychotherapy, ranging from brief cognitive behavioral approaches to longer term kind of dynamic approaches as well, or supportive approaches.
Yeah, I love that the treatment that works is the best one, and treatments that aren't used don't work. And I think it's really helpful to start thinking through not just what works, but how do we help families and adults understand what works and why it works, so they can engage in it. And I love this idea of reviewing all the treatment options available, especially all the evidence-based treatment options that are available. And I think it really hit home dividing up some of those treatments so that patients can understand the different options that are available, like the different types of psychotherapeutic interventions. We often have kids that say, I don't want to talk to somebody about my thoughts and feelings. And we can say there's actually treatments for depression that don't involve talking about all of your thoughts and feelings and terrible things that happened to you in the past. You can actually just work with a behavioral counselor to talk about what you're going to do the next week, to schedule out some of your chores and responsibilities and fun activities, and to focus on you're doing the kinds of things that are important to you. Or there are definitely therapies that dive deep into your interpersonal relationships, or that dive deep into kind of your thoughts and how those relate to your behavior. So being able to have those conversations about the different types of therapy that exist, and to better match them for what they're looking for and what they're comfortable with, as well as medications, and to really explore the pros and cons of each of those options with them.
Great. Here is an example of a decision aid that for depression that you are free to use or to tinker with if you'd like, but it's something that you can think of as an aid in session, in a form that you can give to patients to actually go home and think about too. So if we're talking about depression, we would say probably there are two primary, strong evidence-based approaches. One is antidepressant medication, the other are a variety of psychotherapy or counseling. And we can go through and talk about antidepressant medication first. What is it? How long does it take, for patients to see improvement? how do we think it works? How well does it work? How quickly it starts? Any side effects, et cetera. And then, we engage patients in a conversation and, get them to ask questions if they have a misunderstanding or have a certain myths about medication. It's an opportunity to have that conversation with patients. And the same goes for psychotherapy or counseling. And we can tailor this to, if you have care managers on site, often these are very brief approaches lasting 25, 30 minutes to, external community mental health, for example, may offer traditional 50-minute sessions. So it kind of depends on where these are offered. But it's, again, a way to make sure that patients really understand what their options are and can weigh their preferences and their values. And what they walked in the door with as far as a preference might not be the same as their preference after engaging this conversation with you. So one example that I did want to present is an 88-year-old African-American man who has diabetes and COPD, and he was accompanied by his daughter to a routine medical appointment. And in addition to follow up on a treatment plan for his medical conditions, the physician noted that his total PHQ-9 score was 14 that he filled out in the waiting room, indicating a significant level of depression. The physician did a diagnostic interview and diagnosed him with major depression. On hearing this, both the patient and his daughter had a negative reaction to that, and the patient expressed the belief that, oh, I'm not depressed, only weak people get depressed. On further discussion about what he was going through and what he was facing, he opened up about difficulties managing his illness and difficulties getting around and adjusting to that. When the physician used some decision aid materials and talked a little bit more about what medication was and what counseling might look like in the clinic, and really emphasizing less of a long-term psychotherapy approach and more of a very brief meeting with the care manager to kind of support him and help him cope better with his medical problems and mobility issues, he became more agreeable to seeing that care manager, as did his daughter. In this case, they both remained very skeptical about antidepressant medication and did not want to start that. It did come out also in the context of discussion that there were some transportation barriers and the daughter was not always available to take him to appointments. So positive outcome of a relatively brief shared decision intervention was willing to see a care manager. And also the physician, I forgot to say, also supported their belief and value about religious services and community, and also reconnecting with church and the congregation to help manage his symptoms.
And we can see these skills play out in an adolescent example as well. So I'd like to talk to you about this 15-year-old Nepali female who presented for her well-child check, screened with the PHQ-9, scored a 21, indicating pretty severe depressive symptoms. She had lost 13 pounds over the last few months, low motivation resulting in poor grades and some family conflict. And in this family, a lot of those things that we had talked about prior have been playing out. So the caregivers in this situation really perceived the symptoms as laziness and was kind of confused why she could possibly feel depressed after the family had made so many sacrifices to create a better life for her. The patient, not surprisingly, felt like the parents just didn't understand her or what she was going through. Now, the parents were not allowing this child to spend much time with friends because she wasn't doing well in school, and school was a big value and priority for them. And then both the parents and the child agreed that they're not interested in medication, and both are pretty skeptical, or were pretty skeptical about therapy. So using motivational interviewing, I think the urge is to right away jump in and provide psychoeducation. And while that's going to be important, I think doing that right away and trying to correct the parents' beliefs might be a way to actually prolong your visit by creating this back and forth or getting them to shut down if they disagree with what you hear. And so instead, maybe just reflecting that there does seem to be a problem and reflecting and summarizing what that problem is, which is that schoolwork isn't getting done, that there's a lot of conflict happening, and maybe asking permission to share some information that you have found to be helpful for families in these type of situations. And that psychoeducation can look like talking about the causes of depression and the diagnosis of depression, and really starting to say, you guys aren't the enemy of one another, but there's actually this third person involved here, which is this depression bully, right? So it's not kid against family, it's the kid and the family against this depression bully. And then really describing the effective elements of depression treatment that can help and who can help them out with that. And after having this conversation, they didn't really want to dive deep into the symptoms or what we call it. What they really said is, you're right, we do need to work on this because failing school is not an option. And we do understand that she has to do something in order to keep her mood up. So that way she stays motivated to complete her schoolwork, but we don't want her spending a lot of time with friends. We feel like she might actually be hanging out with some people who don't share our values of education. And so they agreed to allow this patient to do 3 fun activities per week with her sister, her older adult sister, and to also spend some time with the family at the Nepali Cultural Center to talk about some of the cultural components of depression and to get a cultural understanding of it. And the family did agree to check in with the behavioral health provider at her upcoming weight check.
All right, take-home messages. We hope that you agree that physicians can enhance patient treatment engagement by using a variety of evidence-based psychosocial strategies, and that brief psychosocial interventions are an effective and preferred treatment option for patients across the age spectrum.
We also wanted to leave you guys with a few references for further follow-up care and information if you're interested. In addition, we're always happy to reach out or to hear from you. So if you have questions, you can reach out to us, and our emails are listed here, as well as the BHI Collaborative.
Thank you again, Cody and Patrick, for sharing your expertise and experience with our viewers. Be sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on our YouTube playlist. Please also check out the Collaborative's BHI Compendium for a helpful framework on how you can make BHI effective in your practice, along with other actionable resources and practice case studies. Lastly, access the AMA's strategic practice guides on the AMA's website for implementing specific topics associated with effective behavioral health integration, pharmacological treatment, substance use disorder, suicide prevention, and workflow design. Thanks so much for joining us.